Well, hello and welcome to Avinger's virtual series of webinars. Today we're going to be discussing new approaches to treating PAD below the knee featuring OCT-guided atherectomy. We are joined today by a panel of leading interventionists with extensive experience treating peripheral artery disease and specifically addressing the significant clinical challenge associated with below-the-knee interventions. I'll now turn over the call to Dr. Jaffer Golzar, an interventional cardiologist and director of endovascular intervention at Advocate Christ Medical Center in Oakland, Illinois. He's also the chief medical officer at Avinger and director of limb salvage at Advocate Trinity Hospital. Dr. Golzar?
Thank you so much, Phil. I really appreciate it. Thank you, everyone, for being on the call tonight. We're really excited about this important call that we're going to be on, this webinar, and I'm so excited to have such an esteemed faculty, all great friends of mine and leaders in OCT technology. If you're on this call, you know that below-the-knee disease is one of the biggest challenges that we have in the treatment of PAD. There's risk of embolization, there's risk of perforation, and really the efficacy and safety are limited, and therefore a lot of these patients go untreated. Well, we believe that OCT-guided technologies really opens the door and helps with these challenges, and hopefully we'll be able to help explain that to you tonight with the talks tonight. And we'll start by introducing this esteemed faculty to you all great friends, Dr. Michael Lichtenberg, an angiologist and the chief medical officer and director of angiology at the Arnsberg Clinic in Arnsberg, Germany. Beautiful town. I've been there, visited his lab. He has over 20 years of experience in endovascular intervention and is the managing director and president of the German Society of Angiology, a pioneer for sure, pioneer in the evaluation of new medical devices, techniques, and procedures, and has been an investigator of multiple clinical trials. He's board certified in angiology and cardiology and has extensive publications in peer-reviewed journals. Great friend of mine, Dr. Arne Schwindt, vascular surgeon and endovascular interventionist, trained under Professor Giovanni Torsello since 2001, and one of the leading centers in Germany. I've also visited his lab, and a beautiful lab, and he's done some extensive work and one of the pioneers in OCT-guided technology, to the extent that he was first in man to use the below-the-knee catheters, and we did our first in man cases in his lab. He does live cases of very frequently linked sharing cross, TCT, GEM, and really an honor to have Dr. Schwindt today as well. A great friend and a true leader in the endovascular world is Dr. Tom Davis, who's an interventional cardiologist and medical director at Eastlake Cardiovascular and director of cardiovascular research at St. John's Hospital. He's also medical director in Detroit, and he's director of the cath lab and peripheral interventions. And really, he was one of my mentors when I was learning OCT-guided technology, and really I turned to him. So he's really a tremendous resource. He serves on multiple scientific advisory boards. He's worked with new device technology and is part of multiple clinical trials. And then I come to last but not least, Dr. Brad Trinidad, an excellent vascular surgeon and director of vascular and endovascular surgery at Northwest Texas Hospital. He specializes both in open surgery as well as endovascular interventions with an emphasis on limb salvage. He is also the clinical assistant professor of surgery at Texas Tech Institute, and he is very interested in this type of technology and has done significant advances with us in working with OCT-guided technology. So what we want to do today, we're going to launch with Dr. Lichtenberg, and he's going to talk to us, give us a good overview of the challenges that we face in treating below-the-knee disease, and talk about some of the future perspectives on treating below-the-knee disease and critical limb ischemia. Then we'll turn it over to Dr. Schwindt. He's going to talk about OCT-guided atherectomy technologies. And then Dr. Tom Davis is going to present the interim results of the IMAGE-BTK trial, which is a prospective global multi-center trial using OCT-guided directional atherectomy. And then Dr. Bradley, Trinidad, and Dr. Schwindt will be presenting several case studies to highlight the importance of using OCT-guided technology for below-the-knee disease. And then we'll open it up for questions. And without further ado, I'm going to stop talking and I'm going to turn it over to the great Dr. Lichtenberg.
Yeah, thank you very much, Jeffrey. Thank you very much for the introduction. Good morning from Germany, even it is 1 a.m. in the morning. It's a pleasure to be here and to discuss with you guys here about BTK intervention. And I think it's important because we have so many challenges when we talk about BTK disease, and we have so many new and effective options. And one of these great options, OCT-guided therapy, is the topic today. So let me bring you a little bit in the topic and let's discuss about the challenges we have. And we are fully aware that CLI patients have an extremely poor prognosis in terms of survival after they receive the diagnosis. You can see that these patients are on the high risk for dying, will have a high rate of mortality because of BTK disease. So there is definitely a need to take care of these patients, not only about the peripheral artery disease, also on the other issues these patients have, like renal insufficiency, diabetes, etc. We know that these patients are the patients who show up with a high risk of amputation. 150,000 amputations per year due to critical limb ischemia. I think this is a number we are still afraid of. And the bad and the catastrophic thing is that these patients are amputated in many times without diagnostic angiography or revascularization. So even that we have great guidelines available from national and international societies, we're still facing the fact that a lot of these patients do not receive any revascularization attempts once they got the diagnosis of BTK disease and critical limb ischemia. And I think this is something we need to change. And this directly brings me to the topic that this is a significant major economic burden, not only one country, that counts for every country. Just for example, Germany and England, we are paying so much money for these patients. Reimbursement exceeded 1.1 billion 2007 and 1.3 billion 2009. And it will definitely increase during the next year. So we have to deal with these patients and improve not only their clinical situation, but also take care about economic costs. So what is BTK disease? This is classically characterized by a complex morphology. We are fully aware of that from our daily routine business. Long diffuse vessel disease, heavily calcified, total occlusions. These are the typical characteristics of these BTK CLI patients. And we know that BTK lesions are unique and differ from other vascular beds in terms of their morphology. PA, meaning infrapopliteal artery, here is shown. It's more the hard stuff we're going to see here in these BTK disease patients: calcified plaques, fibrotic plaque, chronic occlusion. This is the characterization of the morphology we are dealing with. And this definitely needs a different attempt. If you just inflate a balloon in such a diseased vessel, yeah, of course, it gives you a few minutes, a good lumen, but then it turns back to reocclusion or complications like dissections, recoil, and then we start again, actually. So that needs recoil and dissection. This is the main topic of BTK disease. And the reason is simple to understand why that is. Intimal calcification is disorganized and not structure. Media calcification, the vessel walls organized in structure and increase in shapes. And there are, of course, areas of less or non-disease. And this means that there is always a transition zone between calcification, non-calcification. And if you just inflate a balloon in these mixed morphology, you will see, this was already proven by Frank Braumann from Switzerland a couple of years ago, that a lot of these vessels had evidence of recoil 50 minutes after PTA in one of his studies. And this is, I think, so important to know this fact that just the balloon inflation gives you a few minutes of good feeling, but then you are going back to the same issue you had before. So we all are not doing a good job in these patients. If we just balloon here, we will see a significant recoil after 50 minutes, like in the study from Frank. And then, of course, a bone of this patient is not able to heal. I think this is what we need to understand, and that we have to find ways to deal with these recoil issue. And here you can easily see that also dissection plays a significant role. As mentioned, you have stiff calcified segments, you have soft plaque segments. If you just balloon, in this transition zone area between hard and softer situation, you will definitely get dissection beside of the recoil phenomenon. And this will also lead to recoil, to reocclusion. So wall compliance mismatch is one of the leading arguments why we fail with our standard balloon approaches. And this means that although not all dissection need to be treated, we have to be aware of this dissection or find ways to prevent dissection. As with dissection, we know we have predictors of high target lesion revascularization shown in multiple trials by Nick Shamus, Gunnar Tepe, and also by Dr. Fujihara and Kobayashi. Significant dissection with a failure rate high in terms of early target lesion revascularization indication. And also Arne Schwindt from Leipzig showed us that even after a couple of months in his trial, after BTK balloon angioplasty, reocclusion, restenosis occurred. Doesn't it automatically mean that there is a clinical deterioration, but it's definitely a risk factor if bones are not healing and patients are coming back for reintervention, of course. So we need to deal with that. We have to prevent restenosis by doing better and effective revascularization to keep the lumen open, to prevent early restenosis by these factors, by recoil and dissection. Otherwise, the frequency of complete ulcer healing is definitely lower with restenosis, shown by the Professor Eder, for example, but also in many, many other trials. Restenosis, early restenosis is a fact and the reason for early clinical deterioration. Bones are not healing, patients are coming back. Typical case example here, we just did a balloon angioplasty here in a recoil study, which we recently published and shown as a randomized trial between the scoring balloon approach and the standard balloon approach. And you see that after 50 minutes, we waited 50 minutes after standard balloon angioplasty in this example here. So we saw elastic recoil 100% after standard balloon angioplasty. And this is what we are facing. So we need to discuss how can we prevent this? How can we improve lumen gain over time, prevent recoil, and prevent dissection? That means we have to find ways to step out of this vicious circle of standard balloon angioplasty caused issues like recoil, dissection, then push to stent implantation as a bailout, coming back for restenosis of this failure rate because of instant restenosis. We have to step out here, find ways how can we do this. So the questions are, could we achieve better long-term patency rates with better understanding of lesion morphology using, especially, and this is the topic for today, IVUS or OCT guided intervention BTK, to learn more about the individual morphology and do a dedicated lesion preparation with atherectomy. So OCT guided atherectomy for BTK lesions, I think, is a great pathway to prevent recoil and restenosis issues caused by dissection, because we are improving vessel wall compliance. And with OCT, we also have the possibility to perform an accurate sizing, for example, with the drug-coated balloon technology. Undersizing is a significant topic and also associated with early restenosis. We have to learn how the correct diameter is. This can be easily done by OCT. And these factors can help us to prevent restenosis. So therefore, with these few slides, I wanted to give you a little bit introduction into the challenges we have. And I think it's now time to learn more about OCT technology, how it can help us to prevent restenosis for our high-risk factor patients. CLI is a critical problem. And with OCT-guided atherectomy, I think we have a way to overcome all this issue of BTK disease. Thank you very much.
Thank you so much, Dr. Lichtenberg. Beautiful overview and deep dive of this devastating pathology of below-the-knee disease and critical limb ischemia. and looking forward to doing a little bit more of a deep dive as well during our Q&A session. Arne, I miss you. I miss our late nights doing cases in Germany, but I'm so glad that you're joining us today virtually, and looking forward to hearing your talk. Arne, we can't hear you. You're muted.
Thanks, Jeff, for the kind introduction, and I'm happy to be with you, even if it's only virtual. Now let's talk about this amazing catheter. I try to advance the slides here myself. Thank you. So the thing that catches the eye with using OCT in these small vessels is that most of the disease is not, we are not having pipes in our legs. We have in vessels, in most cases, asymmetric plaque and not concentric plaque. And whatever plaque modification therapy you use, you would like to address only the diseased part of the vessel and not the healthy part. And OCT giving a resolution of 20 microns is like watching the vessel wall under a light microscope. And this is possible by, next slide, please. By this technology setup consisting of basically 3 components. There is the light box. Here you see a picture of the latest version of the light box 3 that is portable. In combination with the Pantheris SV catheter. And what is not pictured here is the sled that transmits the laser and the drive shaft energy into the catheter and receives the OCT imaging from the catheter. Next. And here you see the tip of the catheter of the Pantheris SV, which is for target vessels between 2 and 4 millimeter. It has an imaging fiber directly placed on the cutter. The cutter is a hardened steel cutter similar to other non-image guided devices. You have 3 markers visible on your imaging that are the back of the housing of the blade. And the material you shave off the plaque will be stored in that nose cone. The main differences to the 7 French Pantheris is that the wall apposition is not achieved by a balloon, but by a jog. The blade rotates double the speed of the 7 French device, and you have a working length that is capable to reach the below the knee arteries crossover with 140 centimeters versus 110 centimeters with the 7 French device. Next slide, please. And here you can see what kind of images below the knee you achieve. And I have to say that the more distal you go with OCT technology, the more brilliant your pictures will get. Here you see P3 trifurcation occlusion. Next slide. And moving your catheter in that, you can differentiate between plaque. Plaque is the amorph structure that we saw in the beginning. There we shaved to the elastic lamina. So the catheter has to be reoriented. Now the catheter will cut to the 6 o'clock position. And here you see a dissection in that lesion that can be targeted and cornered and then shaved. And here again, reaching the normal vessel wall, material is packed into the nose cone, and time to reorient the catheter. And we see that we reached the distal end of the lesion and are now in the TP trunk, which is patent and disease-free. And next slide. And here you see, by this, we can, with microsurgical precision, take out the disease out of the artery. And here we're able to connect both the anterior and the peroneal, which otherwise with traditional techniques like coronary stents or ballooning would have been very difficult. Next slide. So I summarize about the catheters. We have the opportunity to optimize debulking by targeting the disease instead of the healthy vessel wall, and therefore avoid adventitious and injury and perforation. We have, especially in asymmetric disease, the opportunity not to harm the healthy part. We can measure the vessel and to have accurate planning for post-ballooning or stent sizing. What is interesting is that you can do long segments of treatment without any radiation because your image guidance is by OCT, not by fluoro. And by this, we also can reduce contrast and radiation exposure to the patient and to the surgeon. All right, I think that's it about the catheter.
Thank you so much. Beautiful presentation. And, you know, I love the images, and it's so fascinating to see the tolerances. You can so easily get into the media and adventitia. And, you know, traditionally before OCT-guided technology, we were using directional atherectomy without any visibility. And, you know, and that's why, you know, that can lead to other complications and a lack of efficacy, because you don't really know how much you're removing, how much plaque you're removing, but also challenges with safety, because you can so easily disrupt the media adventitia, cause perforation, and also you cause trauma, so that it results in restenosis. So thank you so much for that. Dr. Davis, great to have you on board. Again, as I mentioned before, he's a great friend and a mentor to me, and one of the world-renowned experts in OCT-guided technology. He's been doing this since early on, the first iterations of the technology, and he's part of the Image BTK clinical trial, and looking forward to hearing about the interim results.
Dr. Davis, you're muted if you want to unmute yourself.
You're muted. Tom, you're muted.
Is that better?
There you go.
Okay, good. So, well, thank you, Jaffer. That was a better introduction I would give to myself. So I had the pleasure today really of introducing the Image BTK interim result trial. We started this trial as a small trial just to see what outcomes we could achieve with the below the knee device. Next slide. I can't control the slides if you guys can do it for me. Thanks. So the overview of the trial was planned for 60 patients total. So thus far we have just short of that, but we're going to present on the interim data. So the design, as I said, 60 patients in 4 sites. Dr. Michael Lichtenberg and myself here are both the co-PIs for the trial. And the images core labs is adjudicated by CEC as well. So our safety endpoints our goals were primary of freedom of major adverse events through 30-day follow-up. Our primary effective endpoints were residual diameter stenosis less than 50% post-atherectomy. And I think an aggressive secondary one, less than 30% post-atherectomy, as well as adjunctive therapy less than 30%, which those numbers are pretty standard among FDA requirements. Freedom from target vessel revascularization at 6 and 12 months. Primary patency with duplex ultrasound at 6 and 12 months. Improvement ABIs and reduction in Rutherford class. Next slide, please. So these are the inclusions that we had. Mainly the patient had to have intragenicular segment disease. We had to have at least 1 patent vessel to the foot. And the Rutherford class was anywhere between 3 and 6. Exclusions were mainly where the patient did not have any endovascular surgical procedure 10 days before, or there was no planned surgical procedure on the same limb 10 days later. and then the major bleeding events in 30 days. Next slide. So this is the summary slide for the data, and I think this data really, even though it's a small patient population, I think is really showed some incredible light on how well this device does. So enrollment to date is 47 patients, 51 lesions treated, 35 patients have been followed out to 6 months, and 27 patients have been out to 12 months. With, and again, I think these efficacy data, really you don't see below the knee with other devices. A 97% freedom target lesion revascularization at 6 months, 93% target lesion revascularization freedom from 12 months, and primary patency rate by duplex ultrasound of 95% and 92% in 6 and 12 months. And again, I think that when you look at patency in these types of things, the problem that we have with below the knee and certainly treating critical limb is the restenosis and having to repeat procedures multiple times, probably an average of 1.3 to 1.5 procedures per wound that we have to heal. So I think this number is pretty significant. And then the safety, again, everyone talks about how risky it is to do below the knee disease, but with this device, we have 100% freedom of major adverse events at 30 days, 0 all-cause mortality, and 0 major unplanned amputations. So again, I think very incredible data for a small cohort. Next slide. These are the patient demographics, and I think they're pretty similar to many other studies. Actually, Best CLI and Basel II were almost identical with these, with the age of 76, a little bit older, 70% males and 30% females. You can see 70% Caucasian, 30% African American. The ABI numbers you can see they're a 0.78 on the average. If you look at the Rutherford class, the majority of these were Rutherford class 5. And the remainder were split between Rutherford class 3 and 4. You can see smoking and diabetes were probably the major risk factors for this cohort. Surprisingly, more smokers than diabetics. Next slide. So you can see the lesion characteristics here. Our mean vessel diameter was a little over 3 millimeters. And the lesion length was pretty robust, almost 14 centimeters in length. You can see the mean diameter stenosis was 95%. And most of these were de novo with a small amount of restenotic lesions. You can see the vessels that were treated, mostly anterior tibial, but pretty a fair demographic between TP trunk, AT, and posterior tibial. You can see the degree of calcification. Most of these patients had some calcification, with mild being the most significant amount. Again, when we're treating below the knee disease, a lot of this calcium is in the media, and so it's not really intraluminal that we deal with for the most part on below the knee disease, especially in the diabetic population. Next slide. So these are our effectiveness endpoints, and so you can see the mean procedure stenosis 94% pre. You can see a 72% reduction just post-Pantheris with a 20% stenosis rate. So as a primary modality, this is a pretty impressive reduction. And then with post-adjunctive therapy, 9% residual stenosis. So I think that those are pretty effective in opening up below the knee disease. And you can see 95% residual stenosis, less than 50% after Pantheris. And our secondary endpoints, as I've noted before, really extraordinarily good numbers, albeit again a small cohort, but greater than 90% in target lesion revascularization and duplex ultrasound patency up to 1 year. Next slide. I think these are other important outcomes. You can see the baseline characteristics of the Rutherfords. And one thing that to point out in the 12-month slide, all wounds were healed. So this Rutherford 5s all went to either Rutherford 0, 1, or 3, which again, if you look at a one procedure to heal a wound on a limb is pretty significant in today's world of treating below the knee. And you can see the 30-day and 6-month numbers too, as it progresses, improvement in Rutherford class, showing really the durability. Elapsed procedure times, you can see the mean total procedure time, 1 hour and 7 minutes, 8 minutes mean atherectomy time. And again, I think that not having to do this under fluoroscopy really does, once you get used to this, aid in the speed of the procedure. And you can see the mean time from finish to discharge and start to discharge pretty low, especially in outpatient labs where a lot of these are being done and where patients are being moved to as time moves on. Next slide. If you look at the analysis of the excised tissue, predominantly it's the disease that we see. Very small amounts of media. You can see mean percent area of media was about 20%, and extraordinarily small amounts of adventition. Presumably, this is where your regenerative tissues, cells or regenerative cells are going to be that promote restenosis. And so the less you irritate these deeper layers, I think the less provides less restenosis. And you can see the tissue with the adventitia, very trace adventitia amounts in this sample to the right. Next slide. So I think conclusions out of this interim data analysis, Pantheris is a very safe, effective device to improve luminal gain below the knee. And I think that, as was pointed out by Mike, balloon angioplasty has limitations of causing dissections, and you really have to enlarge the vessel with the balloon, which if you have all that calcium that's in the media, you really don't have a chance to break that and enlarge the vessel size to get a adequate lumen. So I think this really does is an important aspect to treating the below the knee. Patient symptoms dramatically improved, as you saw the Rutherford class, and I think importantly, all Rutherford 5s had wound healing and moved the Rutherford class down to 0, 1, 2, or 3. And the ABIs improved significantly with symptoms. And I think the Pantheris SV produces these sustained outcomes over 12 months. And I think, again, treating below the knee disease, and you notice there was some Rutherford 3 in there. I think that, that's been a little bit considered taboo in some circles. And if you look at a durable procedure and a safe procedure, this, I think, will open up Rutherford class 3 to be treated more aggressively for symptom improvement. And I think that's it.
Thank you so much, Tom. Thank you for that presentation. And, when we were developing this study, we wanted to be one of the pioneers in really pushing studies for below the knee to the next level. As you know, most of the studies that we look at for below the knee, especially those with critical limb ischemia, they look at 6-month outcomes. They look at TLR, not primary patency. But we were so confident in this technology that instead of just doing TLR, we looked at primary patency by duplex ultrasound, as well as pushed it out to 12 months. As you highlighted, it's really on track, and really appreciate everybody's contribution to this clinical trial as well, and really leading the way in enrollment. Dr. Trinidad, your reputation precedes you. I haven't been out to visit you yet, but I've heard about all the great things that you're doing in Texas. So looking forward to seeing some cases by you as well as Dr. Schwindt.
Well, thank you for that. I appreciate it. We're out here in the Panhandle. Let's see. Do you have my slides there? Perfect. All right. So great presentation so far. It's been really enlightening. No matter how much experience I have with this device, I can't tell you how much I've already learned in the small amount of time we've already been here today. So thank you. It's an honor to be here as well. Thanks for having me. I have a quick case, just it's just one, but hopefully it's educational. Just to kind of go over some of the benefits of the device, the Pantheris device below the knee, and we'll kind of go from there. So go ahead and go to next slide. So this is right here. I added this picture, and this is everyday vascular surgery clinic for me. Patients with wounds, right? Non-healing wounds. This was a patient who presented to my office, 81 years old, dry gangrene to the left foot. It's been having it for multiple months. Ultimately had a arterial duplex was performed, and obviously, when you have a patient with these type of wounds, you have to assume that there's multi-level disease, what this patient had. Next slide. So took the patient back to the operating room. I do most of my cases in the hybrid operating room, and I did an angiogram. Now I should note that right now we're really focusing on the below knee disease, but as a critical limb ischemic patient, anybody who does a lot of these patients know that there was obviously inflow disease that was needed to be treated at the same time. So we took care of that before this. But usually when I have a patient with what I presume to be either distal popliteal disease, TP trunk disease, tibial vessel disease, I really like to go antegrade. So in this patient, I chose an antegrade approach. Usually when I'm trying to get through an occlusion such as this, so you see here the posterior tibial artery is completely occluded. I like to try from above with usually an 014 command wire and maybe an 018 navicross. That's kind of my go-to. And if I can't get through after a few minutes from the top, obviously I'll come from the bottom if there is a reconstituted vestibule distally that I can approach retrograde. Now, I think one of the important things here is once you get your wire through here, I usually like to try to pre-dilate the arteries with something like a 2 millimeter balloon. I use Cook balloons. Because a lot of the times in these tibial vessels, you don't necessarily have a 2 millimeter lumen, and that's about the size of the device, right? So I noticed that after multiple attempts and trials and tribulations, by pre-dilating the artery with something like a 2 millimeter balloon, really gives you an opportunity to get the most out of the most effective use of the Pantheris device. And so that's what we did here. And next slide. So some of the things I wanted to show here. So it's really important with, and this is one of the benefits in my mind with OCT imaging guidance is it's yes, we're seeing, but what exactly are you seeing, right? So, and I think this is a great presentation here, a great image here to show you. Here we've got a lipid necrotic core, right? So these are bad business, right? So if you go in there and let's say you overexpand this lipid core, right, with maybe an oversized balloon, you can thrombose the entire vessel, right? So by bringing in the Avinger device, the Pantheris device, really allows us to see what exactly the morphology that we're seeing inside the lumen. And these vessels, right, are smaller, right? They're usually long segment blockages, long segment occlusions, circumferential disease pattern usually, or just complete CTO. About the tibial vessels is we don't have a lot of good bailout options, right? So if you get a catastrophic, flow limiting dissection here, or you get some sort of perforation, we don't have a lot of good bailout options to treat that, right? So you want to get it right the first time. And I think that being able to see the lumen from the inside, like the Pantheris provides, is quite beneficial. Next slide. And you can see that here, right? So in this patient, you've got two really areas of calcium, right? You've got this, you've got luminal calcium and you've got medial calcium, right into the media. So it's important to see what exactly you're dealing with. And the importance of this is by seeing the type of morphology and the plaque burden that you have, again, usually circumferential in the tibials, but this could help you tailor, right? Let's say, obviously, as we just saw, the device does pretty well on its own, but sometimes it needs some adjunctive treatment. By seeing the actual disease pattern, it allows us to provide the most optimal treatment for that, right? So let's say we've got a patient with significant interluminal calcification. If you had the benefit of shockwave, maybe that might not be a bad idea. Maybe something like a serenator balloon or some other adjunctive treatment, right? So I think that's really important. You go to the next slide. And then just another slide again showing you, right here you have a compressed media, so we don't have a lot of room here, right? So the lumen narrowing is really caused by this intraluminal calcium, right? So if we over dilate this with a balloon that's too large, you probably are going to wind up with some trouble, maybe a flow limiting dissection. So we really want to tailor our treatment based off of what we're seeing in the imaging. So it's not just seeing it, but it's actually what are you seeing? And that's allowing you to treat the patient optimally, because every patient's different, right? And their anatomy is different. So you need technology that allows you to see that difference in each patient and also treat them. Next slide. So here's our post-intervention. So you see we have a really nice result here. One of the important things when you're dealing with critical limb ischemic patients is you really want to try to do an angiosome-directed therapy, right? You always hear about this angiosome-directed therapy. If you remember back in the picture, we've got a plantar wound on that medial aspect of the foot, of the toe, and we see here. So if we can really open up that posterior tibial artery, which we did here, we actually used a 3 millimeter serenator balloon after measuring with the Pantheris. We had an excellent result. And we've established inline flow now down to the foot. You've got a nice posterior tibial artery. Unfortunately, the image kind of cut off here, but if the image continued down, you would see the plantars feeling, you would see a nice wound blush, right, where the wounds were. And that's what you want to see, right? That's how you treat critical limb ischemia. You have to get inline flow and you get down to the angiosome of that particular wound. So I think that, as you can see, we had a really successful outcome here, but we weren't able to do that without seeing exactly what we were dealing with, and that's what the Pantheris allowed us to do. Next slide. So again, this is basically a summary of what you've seen previously in the other slides, right? By having the Pantheris device in there, it really allows us to see, are we in the right place, right? Are we in a dissection plane? Are we intraluminal, right? That's one of the most important points. B, what type of morphology are we dealing with, and how should we approach it? And then 3, what's the size of the vessel? Are we going to appropriately manage it with the appropriately sized balloon? Whether we make sure we don't want to overdilate, we make sure we don't want to underdilate. We want to make sure we treat the patient to the size of the artery so that we get the best long-term results. And I think that the Pantheris really provides that. Again, some of my tips are, trying to get down, especially if you're going down in the AT, you really want to try to pre-dilate with the small balloon, and that'll really make it a little bit easier for you to get that device down, especially once you start getting into those tibial vessels. That's all I have for you guys.
That's an exceptional case presentation. Thank you so much. And, I'll just make a comment on the medial infiltration of calcification. And, when we did our first in-man cases, we started to see really the predominance of this medial infiltration of calcification, because most of the time when we see calcium below the knee, we think it's luminal calcium. And we haven't had the high fidelity imaging that OCT gives us, because you just can't tell with IVUS. And traditionally, if you use orbital atherectomy or rotational atherectomy, that's really not going to do much for this type of calcium because it's deep wall calcium. And so really most of it is soft plaque with deep wall calcium, but you see this under fluoroscopy, so we assume it's luminal calcium. So it really helps us a lot to be able to see that imaging. One of the questions, I'm just going to ask a question because we've starting to get a bunch of questions in. How many of you actually post-dilate after atherectomy in terms of adjunctive therapy? Arne, I'll have you answer that question and go into your case.
Well, I post-dilate always. And what we could discuss is, since there is, very weak evidence that DCBs work below the knee, up to date, whether we should post-dilate with drug technology or if we should post-dilate with more modulating, like scoring balloons, serration balloon. There's still much research to be done, but I post-dilate all cases, and I'm going to show you in my case also why this makes sense. All right. Let's go to another case. This is actually one of the trial participants, patient with first or big toe tip gangrene, 87-year-old male, still smoking, hypertension, very low ABI. And this is a reocclusion with POBA plus DCB 5 weeks prior to the intervention I'm going to show you now. And then as Michael showed in his presentation, coming back because initial relief for 1-2 weeks, then, again, rest pain. And then when the patient comes back, you find in duplex that your target lesion has reoccluded. The angiosome related artery here is the anterior tibial artery. We see here that there is an occlusion from about the mid part, and then reconstitution at ankle level with a nice dorsal pedis artery with CTO 100% stenosis. I came integrate here. I crossed with a 018 command via 018 quick cross as support. And then we went in with the Pantheris SV. So what are the options in patients like this? He already had PTA and DCB, and I like this quote from Einstein, who said the definition of insanity is doing the same thing over and over and expecting different outcome. So we have to do more in these patients that come back early. Scoring PTA is a possibility. Stenting is not a possibility in this patient because the lesion is in the moving zone at the ankle level, and I'm not aware of implants that do a good job in this transition zone. Atherectomy, then the question directional, rotational. Image controlled, and I'm not a specialist in English semantics, but I think the big difference between Pantheris SV and using IVUS in these patients is that IVUS therapy is merely IVUS or image controlled. You do a therapy, then you get in with your IVUS device, check what is the outcome. Then you adjust your therapy, do another step, and then you go in again with your IVUS fiber. And it's not really IVUS guided, it is IVUS controlled. And in this patient, we went for image guided therapy with the Pantheris. So let's have a look at the loop. So what I do first is I do a 360-degree check at the beginning of the lesion to see where the plaque starts, and moving slowly forward. And then you see this amorph matrix on the 10 o'clock side, and then you can cut by moving your catheter forward. I pack always after like 5 centimeters. And here you see we reach completely normal vessel wall and the media. Here we do another cut, and this is, a cut down of 12 minutes of OCT guided. And I slowed the loop down because here I'm again close to the media, and I change the direction of the catheter. And here you can nicely see the trough and the amount of material that we take out with these runs, Here back to normal speed. And again, cutting. And here again. And you see how nicely controlled. You can always stop your action before you do harm to the patient. And then we did an angiogram, and we had no lumen, spasm. So no reason to panic. We know from the above the knee trials that, dissections and flow limitation is very rare after OCT-guided atherectomy. So we went in with a DCB, in this case, a Biotronic 3 millimeter Paseo, in 2 levels, and did a PTA and achieved this result. With very nice outflow to the foot and to the lesion on the big toe. So as Michael already said, when we use traditional therapy, balloon-based, we don't do the patient right. 97% of the patient have recoil. This is a principle of physics. You cannot make matter disappear. But we can move it. What do we know about atherectomy below the knee? This is a nice meta-analysis done 2 years ago by my friend Yorgos Pitoulias, where they said, on the data that is available and the trial data that is available on below the knee atherectomy, it seems to be safe. And it shows a better outcome in the 1-year follow-up. This should be a predominant role in modifying the plaque and removing plaque from the below the knee arteries. Here again, elastic recoil, early restenosis are the Achilles heel of traditional BTK revascularization. We can address that with OCT guidance. We have good luminal gain in these patients. This was highlighted also by Tom Davis in the tray data we just saw. And what I really like compared to the old times when we did not image-guided directional atherectomy, you can do that without fear, very controlled. Everybody who has done below the knee atherectomy before image guidance has caused perforations. And I haven't seen a single one using this device in my practice. Thank you for your attention.